Welcome, everyone. Good afternoon, and welcome to Medicine Grand Rounds. Today, this is a very special Grand Rounds, which is entitled the Cardos Renal Grand Rounds. I'm Lakshmi Santosh, and I'm the Director of Grand Rounds here out while Bob Wachter is out on an out-of-office trip this week. And we're going to talk to you about a very exciting topic today. We are very honored to have our visiting professor, Dr. Chris Chan, here visiting us from the University of Toronto, talking to us about the changing model of policy, economics, basic science, clinical science, implementation science, and education regarding dialysis, particularly new innovative technologies regarding home dialysis. And so a little bit more about Dr. Chan. So Chris Chan graduated from the Faculty of Medicine at the University of Toronto in 1995. He completed his postgraduate training in internal medicine nephrology at the University of Toronto, and then pursued further training in cardiovascular physiology. He joined the Division of Nephrology at Toronto General Hospital in 2002 and presently serves as the Director of the Division of Nephrology, Professor of Medicine, and holds the R. Fraser Elliott Chair in Home Dialysis. He's also a Deputy Physician in the Chief of Economics and Medical Lead of Connected Care at the University Health Network. He's also the Associate Editor for the Clinical Journal of the American Society of Nephrology, ASN. And for many of you who've been following on social media, it's a big time for ASN with their Neph Madness tournament that they have on social media. And Dr. Chan is a well-known speaker in this area. He's contributed over 200 peer-reviewed publications, multiple book chapter in the field of home dialysis. And his research really is about the clinical, genomic, physiological changes, cardiovascular disease in CKD patients, sleep disorders, and he really has championed and defined the clinical use of home dialysis, coordinating a very large network which leads the clinical and basic science aspects of optimal dialysis delivery. He's received multiple awards, most recently the Temetry Faculty of Medicine's 2020 Dean's Award for his leadership and national, really international impact on renal replacement therapy. We're a warm welcome to Dr. Chan today. And as always, we'll have our closed captioning available for folks to please type your questions in the Q&A so that we can moderate them. And remember that stay on afterwards for a minute or two to get CME credit as always. Dr. Chan, thank you so much for joining us. A warm welcome to you.
Thank you once again for that absolute generous introduction. Let me share my screen. I hope that everybody can see my screen okay. Once again, I'd like to thank the organizing committee for the invitation. It has been a tremendous honor for me to virtually visit UCSF and was able to deliver the Cardos lecture. Today, for Grand Medical Rounds, I thought that it would be more appropriate to talk about the practice of dialysis and some thoughts about policy, education, and perhaps some economics. Here are some of the disclosures appropriate for this presentations. And a word about Dr. Cardos. During my visit, I have the honor to meet Dr. Cardos' family. He had played a huge role in the clinical application of dialysis in UCSF. He really truly was a Renaissance man, and I am again very honored to provide today's lecture in his memory. So let me talk a little bit about home dialysis. And again, some of the objectives about this field is really quite vast. And there is a global trend regarding the increase in home dialysis when it comes to both home and also personalized dialysis. Clearly, from a patient perspective, there are ongoing growth of the end-stage kidney disease population. There is a heterogeneity in terms of both awareness and education about home dialysis. Yesterday, I talked to the Division of Nephrology and exchanged ideas about clinical outcomes, both in terms of survival, other surrogate outcomes, as well as patient reporting outcomes. Clearly, there is a key role in how the providers are going to change the dialysis practice. And in this talk, I'm going to talk a little bit more about overcoming education barriers, and with two focus, one on patient education and the other one on education for providers and particularly physicians. There's clearly a lot of attention on home dialysis recently. With most recent executive order and using Advancing American Kidney Health Initiative, there is a momentum to actually grow home dialysis as well as prioritize preemptive transplantation. And indeed, looking at that executive order, there is a lofty goal of having about 80% of all patients doing home dialysis or having a preemptive transplant. Currently, the US national average is hovering less than 20%, and so there's a lot of work to be done. Having said that, well, multiple different peer-reviewed journals have had editorials as well as task force in looking at the role of expanding home dialysis and the call to action in our global community to initiate the important work that needs to be done, both in terms of allowing our patients to understand home dialysis, the knowledge that needs to actually occur, knowledge transmission also from the nephrologist perspective, as well as other allied health members. So there's a lot of hope, there's a lot of renewed interest, and also it is an aspirational growth. So how do we grow home dialysis? And again, there is clearly going to be multiple steps that need to happen, and training is going to be key, both in terms of training for our patients and also training for our physicians. On top of that, we also need to understand how to decrease attrition. Yesterday, we had an opportunity to talk about, with the Division of Nephrology, various strategies about mitigating decrease in attrition rate in home dialysis. More importantly, how do we know if someone is actually ready to go home from a patient's perspective? And I'm going to share some ideas with you today regarding some of the tactics and strategies that we have actually employed. Now, why home dialysis? And in particular, why home hemodialysis? Time doesn't permit me to go through all the various important studies that there has been done over the last 2 decades or so. It suffices for me to say that there are potential benefits in improved quality of life. There's certainly an improvement in lifestyle. We and others have invested lots of time and efforts in demonstrating the important cardiovascular risk reduction in increasing both duration as well as frequency of dialysis. Certainly, when we increase frequency and duration of dialysis, we are able to ameliorate this peak and trough curve in both volume as well as solute control. As we are able to enhance dose of dialysis, we're also able to liberalize diet. Yesterday, we also talked about the feasibility of having full-term pregnancy, and indeed, there has been a baby boom in Toronto, having significant changes in how we handle pregnancy in dialysis patients. And we also talked about both the pros and cons in current observational study, tackling the idea of survival advantage. However, before we can actually realize all of these goals as well as clinical benefits, we need to understand how we actually use this strategy most efficiently, as well as with the shared decision making that all patients need to have to actually transition to home. Let's see what happens overall in the last decade or two in terms of use of home dialysis. This is the most recent USRDS data that is available now openly. And in fact, as one of the few non-American committee members on USRDS, you might be interested to know that there is now a home dialysis chapter in the USRDS outlining all the progress that people have made in the field. Clearly, you can see that home dialysis as a whole, in terms of home hemodialysis in the red, as well as preemptive transplantation, and in addition, peritoneal dialysis, there's clearly been a steady and an impressive growth. So I think it's important for us to address the fact that there is indeed progress. However, notice that the denominator here of all the numbers in terms of both peritoneal dialysis, preemptive transplantation, and home hemodialysis. Let's compare that to a much bigger number. in the in-center hemodialysis population. Overall, although there is significant growth, it is dwarfed by the number of patients, both in terms of prevalent numbers as well as incident numbers going to the in-center conventional hemodialysis. Let me also pause a little bit about the global differences. There is a clear heterogeneity in terms of dialysis practice pattern across the globe. Here is an outline of the amount of investment in terms of per capita investment, as well as the amount of percentage in peritoneal dialysis, the amount of the percentage of central venous catheter, as well as different type of kidney transplantation prevalence per million in population. So overall, as you can see, the amount of heterogeneity and global pattern is highly divergent, and a lot of it also has to do with the systems. Over and over again, we can see that Australia, New Zealand, and Canada often had been quoted to be a significant champion in home dialysis. And here are some of the usual factors that actually been talked about. And these are the usual prevalent numbers that has been talked about as well. Now, it is fair to say that there is a difference. Clearly there is. And why is there such a difference? I think a lot of it has to do with system. Let's think about that a little bit more and discuss. So in terms of patient selection, I can tell you that for most of the last 2 decades at UHN, we have considered home dialysis as the preferred modality, and that at home dialysis in our CKD clinic at UHN, home dialysis is the preferred modality, and hence really we don't often get into the mode of contraindications. Patients who are able and stable and motivated, who has housing and able and willing to learn, we will try to actually provide home dialysis as much as we can. Oftentimes, we will give them the idea and also the advantages of more intensive and also home dialysis, and also to understand that the key for actually encouragement for home dialysis is really has to do with education. Pre-dialysis education at the level of chronic kidney disease clinic, encouragement from other patients, as well as peer-to-peer support. As you know, as a nephrologist, we often think very systematically, and just like this, we also think about the home dialysis pathway as in pre-home dialysis, pre-home HD, during home dialysis, and also after home dialysis. How do we actually make sure that patients are able to enhance the uptake of home dialysis programs maximally? And from a pre-home hemodialysis perspective, we specifically think about the training and the pipeline of allowing patients to develop self-care and also to understand the individuality of learning. And I'll say a little bit more about that in a few minutes. Most recently, there has been a significant growth is what is known as transitional care unit or transitional dialysis unit. And again, this is a way or a strategy or tactic to actually allow patients who may not have known that they have had chronic kidney disease, and also more importantly, to understand that there are other modalities outside of in-center hemodialysis. Oftentimes, a nurse navigator are used in the transitional care unit to continue to understand and also educate what kind of dialysis modalities are available. During home hemodialysis, we and others have implemented different type of auditing as well as virtual ward to support our patients and also to maintain our patients in a complex environment. Finally, post-hemodialysis and perhaps post-home dialysis, a tactic that's very much important to actually think about is home-to-home transition. How do we create an integrated strategy to allow patients who may be used to doing home dialysis, for example, peritoneal dialysis, to transition to home hemodialysis when the time is correct? Underlying all of these transition nodes, how do we actually assure training? And I think this is one of the domain that I'm going to expand on significantly within the idea of medical education, and also borrowing some ideas and themes from medical education to patient education. As I mentioned before, why do patients actually choose self-care or home dialysis in the first place? Yesterday, I had a very productive discussion with different faculty members in the division of nephrology, and I often openly admit that although my research speaks to the cardiovascular advantages of home hemodialysis, in the last 20 years, I have never had a single patient come to me asking for improvement in blood pressure and or regression of left ventricular hypertrophy for adopting more intensive home hemodialysis. Whereas the most common reasons why people want to think about self-care or home dialysis, and particularly home hemodialysis, are these three domains: freedom, lifestyle, and control. And I think it's really important for patients to understand that the autonomy, the possibility to actually controlling their own chronic disease management is hugely important, and often actually perhaps ignored or forgotten when we're operating in an in-center hemodialysis mode. Oftentimes, when patients are approached or actually sometimes crashed into our hospital with chronic kidney disease or even end-stage kidney disease, the default mode of dialysis is that of in-center hemodialysis. And in fact, most patients actually that start acutely in the hospital happen to go on to in-center hemodialysis uniquely about 98% of the time. We started using a different modality or a strategy to actually educate patients who are acutely starting dialysis in our hospital. During the time period of 2005 to 2009, we use a nurse navigator, acute nurse navigator role to actually educate our patients. These particular so-called crash start patients were provided CKD modality education in the hospital. And while our previous historical control will tell us that 98% of these patients will go and stay in in-center hemodialysis, we're able to actually have a 60-40 split where most of them actually go to in-center hemodialysis, but a significant group of them actually ends up in home dialysis. We also talked about a minute ago about the assessment of readiness. When someone actually is faced to go on to dialysis, it's also often difficult to really truly understand if they A, know about dialysis, B, educated about dialysis, and C, if they're even ready to understand how dialysis may impact on their lifestyle. Because of that, most recently, and especially in the US, the transitional care units have really started as a trend, looking at really designing a way to stabilize patients who is new to dialysis, to understand in depth what modality education and other impact of dialysis may be, to also provide emotional and psychological support of doing dialysis, and provide once again this idea of patient navigation to understand and also to increase the uptake of home dialysis or more independent dialysis forms. This is truly a very open area. And I think to date, there has been little data. And so I would encourage people to think about using this type of modality. At the same time, would be even more important to understand the metrics of success if transitional unit can actually enhance both patient experience as well as modality decisions. It's also interesting to think about training. Training in home dialysis, both in home hemodialysis and peritoneal dialysis, has been a unique skill set, particularly through the nursing colleagues. However, if you actually look at the standardization of training, that's been lacking. And here is a table that we published looking at the training program parameters for home hemodialysis across the world. And you can see that the number of training sessions, the duration of training sessions are vastly different, with the highest training duration in Auckland, New Zealand, where the penetration of home dialysis is in fact 50%, whereas in the shortest duration of training, which is in fact actually in the US, where the home dialysis penetration is actually the shortest and also the fewest. So it is interesting to note, or maybe to hypothesize, that perhaps if we invest more in terms of home dialysis training, that we're able to actually not just increase the original initial uptake, but more importantly, the maintenance and mitigate attrition of patients leaving home dialysis. And indeed, how do we actually determine training success as well as technique failure? And this has been an interesting descriptive type of epidemiology where we and others have started looking at this. And here, this is just a synopsis in some of the Toronto data where we define failure as never able to complete training or failure within a year of home modality. And clearly, there are a mix of both medical and diabetes is a key factor, as well as psychosocial factors. For example, housing, which actually is a keen independent risk factors for failing home dialysis. Similarly, with looking at the US data, this is data from DaVita facilities, that there is about 25% of patients discontinuing home dialysis within a year. Once again, a combination of medical as well as psychosocial, and social determines health. If we actually also think about patients as learners and also how individual may learn differently, it is actually quite an interesting observation. In this particular piece of work, we started actually looking at our patients as individual learners, and we wanted to understand what their learning styles were, and also if their learning styles actually change and or actually are associated with adverse events. So we used the VARC questionnaire, where V stands for visual, A, auditory, R, reading, and K, kinesthetic. And we want to understand if a different learning preference actually associated with different adverse events. And to make a long story short, using our cohort, we noted that visual versus non-visual learners, the visual learners are actually associated with a protective effect of vascular adverse events. It is interesting or maybe speculative for me to hypothesize that a visual learner may be able to have a predilection to allow the image of cannulation into the vascular access, and perhaps this might be one of the reasons why a visual learner actually is indeed in an advantage situation associated with less likelihood of developing vascular access events. Having said that, it doesn't mean that all the other type of learners are in a disadvantage. It probably speaks to the fact that we as teachers have to actually adjust and understand the individualization of how training ought to be. That leads me to the second question of how do we actually assure home dialysis training is in fact actually done appropriately and also correctly? And how do we also document that in order to actually understand how home hemodialysis, which is a relatively complex medical skill, into someone who had relatively few past medical training? So we decided to use different medical education techniques. In this case, the use of OSCEs. As many of us are aware, OSCEs, or observed clinical exam, are often used in medical education for our trainees, medical students. And we decided to actually use OSCEs in this particular case to assess the readiness of patients going from a naive state to actually ending of the training. And in this case, we also actually use global rating scales to actually rate our teachers and also our students. It is interesting to note that with this particular assessment, we're able to standardize our training better and also increase the confidence of our patients transitioning to home. Similarly, other methods of training has been used in medical education, particularly in medical simulation. As everyone's aware, looking at this slide that I borrowed from DaVita, they are also thinking of using Simulab with, for example, peritoneal dialysis catheter insertion, and also in other industries, thinking about flight simulation. And indeed, we also use this strategy to actually build out a simulation room for patients to actually undergo home dialysis training. And in fact, in our situation, the last week of home hemodialysis training is associated with an independent assessment in which the patient is actually undergoing independent dialysis and also have an entire simulation of the home environment. Over a three years period, we're able to actually assign 30 patients as cases and 23 patients as controls. It is interesting to note that with this particular strategy, we're able to have a trend or decrease in home dialysis nursing visits into our patients, perhaps actually giving us once again the signal of increasing confidence in our patients transitioning to home. Let's also talk about the measurements. Here is a plot of the prevalent home dialysis rate across the province of Ontario. And once again, you can see that although the target of Ontario is up to 40%, few centers actually achieve that all the time. This tells us that there is clearly heterogeneity across a region, and perhaps actually allowing the multi-cohort center way of assessing technique survival is important. And also understanding if there are particular aspects of a center versus another one that actually allow that technique to be improved. And indeed, we and others have started actually looking at this in an anonymous way to understand the technique success or failure rate across the board. In this particular graph, you can see that we plotted the technique survival or technique failure rate in the on the y-axis, and on the x-axis, the patient years on home hemodialysis. I can identify for you that UHN is the Y circle, and that across the board, we see that there is a scatter of different number of patients as well as different number of technique survival. As known within the literature, there might be a critical mass effect that larger centers do better than smaller centers, perhaps because of their expertise, which also create the possibility or notion of a virtual mentorship or mentorship program from center to center, which we have started. Furthermore, if we actually project our dialysis numbers, this is Ontario numbers, and you can see the projected volume from 2017 all the way to 2027. Clearly, across the board, in all jurisdictions, we are seeing a growth of dialysis patients. And in order for any jurisdictions to actually meet this ESKD demand, there is not enough spots or nursing that is there. So the idea of growing home dialysis is very sound. Let me switch gears to now think about during dialysis or during home dialysis. Are there tools that can actually increase our patients' knowledge awareness and also allow us to continuously educate and perhaps improve the quality? And I'm going to use the example of vascular access audit and infection. In order for any patients to undergo home hemodialysis, they have to become expert in cannulating their own vascular access. And indeed, using an idea and technique through the CDC to actually develop a vascular access audit chart. And then every time that they come to clinic, we go through the same vascular access audit chart to reinforce the technique as well as the medical education aspect of it. We also derived an estimated probability of number of errors that the patient can do versus the likelihood of actually having an infection. Indeed, when we actually look at our cohort, by the number of audits that we have done, we can once again reassure ourselves that we're able to teach our patients the importance of vascular access and perhaps reducing the number of errors and on perhaps ultimately translating to a reduction in infection rates. In another project that we have done, an important aspect is how do we maintain our patients' technique survival overall? And we use a concept which I think is probably very common to many of you, the idea of a virtual ward. So in this particular project, we have identified 4 important at-risk groups of patients, especially for transition of care. In here, we use a multi-center prospective study to actually particularly target patients who are just finished their home dialysis training, who had a specific vascular access or peritoneal access procedure, or post-discharge home, and then also oftentimes with IV infusions, most commonly IV antibiotics. We were able to show that by using a regular standard virtual ward questionnaire and also regular standard timing to round with our patients, either by phone or by video, our team was able to show that there were potential care gaps, especially in patients after the discharge, and also in particular vulnerable moments. And the vulnerability moments are really in terms of transitions in care. So let me summarize so far. Home dialysis is an increasing global trend. More and more, we're going to be asked as a nephrologist to understand the training and also increase the number of patients adopting home dialysis. I think we have used the strategy of borrowing some medical education theory to translate that to increase competency for allowing patients as individuals to competently conduct a skill. We also see a significant need for assurance of patients' training, which overall in the field has been lacking. And I think this really allows us an opportunity to implement clinical assurance trials, or maybe perhaps cluster randomization trial to really test these hypotheses. Furthermore, there remains a very significant barrier for home dialysis, which is knowledge awareness. And I think there is knowledge awareness which is lacking both in terms of patients and also, more importantly, from nephrologists as well. Education for home dialysis opportunities are often episodic and not usually longitudinal. There has been few opportunities for dynamic or hands-on or immersive type of learning. There's also few existing pathways to really establish a long and ongoing mentorship between a center of excellence versus those who actually may not have as much experience in home dialysis. And there's been limited exposure in fellowship for home dialysis education experience. And some of this data has been reflected by both ourselves and also other investigators looking at education needs. So in this particular JASON paper, a survey was done to 266 fellows and other recently graduated nephrologists and asked a very simple question. Which topics would you most like to receive additional instructions during your fellowship? Interestingly, the leading answer is home hemodialysis. About 50%, more than 50% of trainees want additional instructions. And then the number two answer was peritoneal dialysis. Again, showing that home dialysis training perhaps is a gap in the current US training programs. So if we perceive that home dialysis is going to be a growth trend, there is a policy in ensuring that we're going to be gaining more home dialysis patients. There's clearly a clinical advantage of allowing patients to do more home dialysis. In particular, yesterday I discussed about frequent and more frequent home hemodialysis. Can we continue to do the same thing over and over again and hope that we will have different results? How do we actually change the delivery of education and or mentorship to enable our nephrologists to be more aware of home dialysis? So in this particular project, we made use of a ECHO project, which is an intent to use virtual physician mentorship to actually increase home dialysis knowledge awareness and perhaps uptake. What we did was a partnership with Satellite Healthcare, with UHN, and also with GlomCon. And some of you may be aware of GlomCon, which is a digital fellowship. And we used the GlomCon platform to actually put together a collaborative demonstration project. We also use this as an ECHO-based project to ensure that we have an informal, but yet a sustained platform for a 6-month engagement. We enrolled 40 physicians at various training stages. And we also have an outline for the rationale of why this might be important. And the objective of this project is to understand both the feasibility as well as the impact of doing a virtual physician mentorship. Does it actually change the physician's home dialysis knowledge awareness? So let me show you some of the baseline demographics and some of the data. So in here, this was the demographics baseline in the 40 nephrologists that we enrolled. You can see that there is a smattering of age, differences in gender. The race breakdown is reflective of that of a Californian-based nephrology cohort. These are some of the physician and their practice attributes in terms of years in practice, the total number of home patients that they may have, the number of PD patients, as well as home hemo patients. It's also interesting to see how they would attribute themselves in terms of, are they the medical director at the center that offer a dialysis at home? Do they also have both offerings in home as well as in-center hemodialysis? Do you only offer in-center hemodialysis? And also, how would they describe the nephrology practice? We ask how confident at baseline for our enrolled cohort in terms of contraindications of peritoneal dialysis, as well as counseling patients about trying peritoneal dialysis or home hemodialysis. And you can see that overall, our cohort seems to be quite confident in home dialysis, which perhaps actually suggests that we were mostly attracting physicians who are already interested in this topic. We also talked about how confident our enrollment were in terms of writing and adjusting prescriptions for PD as well as home hemodialysis. And overall, our cohort seems to be quite confident. Now, you might then think that if we already enrolled only home dialysis zealots and were enthusiastic, then we may not be able to see any much difference by doing this platform because they already know about home dialysis. So let me show you what our exit survey results were. So in fact, on a scale of 1 to 10, in our home dialysis mentorship program, we were able to actually change our cohort overall to even shift their attitude towards prescribing home dialysis, to think about home dialysis, to also recommend home dialysis mentorship. It is also interesting to note that our physician colleagues, even though during the pandemic has been inundated with virtual Zoom conferences, it is in fact actually quite astounding that 88% of our physicians actually preferred a virtual platform rather than in-person education. It's also interesting that despite the fact that at baseline, most of our physicians felt that they were quite confident, at exit, we were able to shift even the quote unquote not so confident people into a higher degree of confidence, both in peritoneal dialysis and more so in home hemodialysis. Interestingly, the confidence in other peritoneal dialysis catheter surgical techniques were also noted, and you can see that at baseline and then versus the exit category. You notice that at baseline, that a significant fraction, about 23%, had no confidence or not familiar with it at all in terms of PD catheter surgical techniques, versus at exit, that most of them were either very confident or somewhat confident. Additionally, when you talk about adjusting and writing prescriptions in home dialysis, both PD and home hemo, once again, even though that at baseline, most actually felt that they were quite confident. In fact, we're able to once again shift everybody to the right, looking at either a somewhat confident to very confident, both specifically in peritoneal dialysis, as well here in home hemodialysis. An interesting aspect of starting peritoneal dialysis in patients who have acute kidney injury were also noted. urgent start peritoneal dialysis was not a familiar topic to our nephrologists at baseline. Once again, at exit, where they were able to actually accomplish much more confidence. And peritoneal dialysis for AKI, once again, was demonstrating a significant degree of confidence. Here are a listing of different complications of peritoneal dialysis. On each of those specific topics, they're able to show baseline as well as exit number of confidence. Once again, we are seeing a uniform trend looking at the ability to manage complications in home dialysis, both in peritoneal dialysis, and once again, here in home hemodialysis. And the topics were wide-ranging, thinking about buttonhole cannulation, water quality at home, how do we actually select patients to go towards home hemodialysis, the various type of modalities, such as nocturnal home hemodialysis, the different type of machine, as well as prevention of technique failure, which we spend a lot of time actually talking about. So once again, in summary, this particular project brings us some hope that home dialysis physician mentorship is feasible. And in fact, the use of a Project ECHO model through virtual care is actually quite an interesting way of delivering education. 53% of our participants perceived that our program would change participants in their practice behavior. Obviously, we still need further research to understand how this really truly impacts the actual incidence and attrition rates in home dialysis, not just simply attitudes of our physicians. I think it's also important to acknowledge that this was a collaboration with a dialysis organization and also with GLOMCON. I think, however, the implementation of this type of program had been quite novel. And so I think it's actually still an important aspect that we should think about. And maybe perhaps during our Q&A session, I can elaborate further about another project that we just finished with collaboration with the National Kidney Foundation in a specific ESRD network, and also some of our discussion with ASN and also NKF. Finally, let's talk a little bit about finances and also system differences. Canada is a single-payer dialysis system. So overall, the number of dialysis patients in the country is 1/10 of that in the US. And I've shown you the incidence and also the various demographics of our dialysis population. A lot of times, people are very interested in the reimbursement rate. Perhaps the reasons why the reimbursement of home dialysis is more advantageous, and hence there is an increase in the number of patients doing home dialysis because of that. I can tell you that as a nephrologist, I receive the same flat rate of reimbursement doing no matter which type of dialysis, either in-center or home dialysis, be that home PD or home hemodialysis. You can also see that the Canadian versus the US operating budget differs significantly. And overall, I think it actually speaks to the fact that practice culture and also education efforts is quite divergent between the two systems. And there are going to be different instrumental and incremental steps that needs to happen in order for dialysis practice to change. So let me summarize. I hope that in the last 45 minutes or so, I've been able to actually convince you that home dialysis is an interesting, but also a uniquely positioned area for growth in end-stage kidney disease. There is a very unique system, patient, and provider alignment right now, especially in thinking about the policy that just has been established with Advancing American Kidney Initiative. It is going to require a significant amount of lifting, particularly in education as well as human resources, in considering the aging population, the changing in technology, and also the amount of difference in expectation and how we assess value these things. I think, and I hope that you would agree with me, that there is a vast amount of education research that we can do in allowing our patients to understand and undertake these complex medical procedures closer to home. It is also our responsibility to ensure that medical education is assured and that patients are able to be ready to actually go home. Perhaps that reassurance is some of the underlying differences between US and Canada in terms of technique survival. And there are also mitigating strategies that I hope that I've illustrated for you to enhance the technique survival of both home hemodialysis as well as home peritoneal dialysis. With that, let me close and thank you once again for this honor to be the Cardos lecturer today. And also, I would like to thank the Division of Nephrology at UCSF for hosting this. This has been a tremendous honor for me. And also, once again, thank you for your attention for attending rounds today.
Thank you so much, Dr. Chan. That was truly a whirlwind hour. We talked about policy, medical education, implementation science, the digital world, and you really had something for everyone. We all learned a lot about this topic, which, like you said, there are worldwide variations on the uptake, but also regional variations in the US. You commented about the worldwide variations, and we talked about the payment scheme as being kind of one payment structure as being kind of one of the determinants. What do you think might account for the regional variations within the US itself? Does it all come down to what you talked about, culture and education?
Yeah, so thank you once again for those comments and remarks. I think there has a lot to do with practice pattern and also the clinical championing of home dialysis. As I mentioned in the survey that was published in JASN, if a nephrology trainee is not exposed to home dialysis, it is unlikely that when the person graduates and become a nephrologist in the community, that he or she will be comfortable enough to actually prescribe this particular therapy. There's also the need for mentorship and support for centers to actually grow. Even if you have had the willingness to actually enhance and deliver home dialysis, it is important for you to actually have this backup and support to actually encourage the growth and also the medical collaboration for other aspects of home dialysis. For example, the surgical help in inserting peritoneal dialysis catheter, the backup that you might need when someone is not doing well at home, that you need to do backup dialysis in your training center, the way to troubleshoot different complications of home dialysis and so on. So I think there's regionalization because there might be regionalizations of home dialysis hubs that are heterogeneous across the US. It is interesting to note when we were discussing about the USRDS atlas, there is a bimodal distribution of home dialysis training centers in the US. There is a cohort, which is far right in the curve, that has more than 20 patients, and there is a significant cohort that has less than 5 patients. So if you have a center that has few patients, your knowledge awareness and your readiness to act is going to be very different than centers that are much more comfortable in dealing with patients at home.
That makes a lot of sense. I think you really highlighted nicely how it truly takes a whole structural effort, truly a team effort in the community. I loved your outlining to us the digital ward. We have a great question from the audience that comments on that, which is, can you comment on the pros and cons, or structurally, how do you do training the patients at home instead of at the dialysis center?
Right. So that's interesting. The idea that home dialysis has to be done in terms of training in a center has been debunked. People actually have done home dialysis training in patients' residence as well as different skilled nursing facilities. And so I think it is important to really have a huge amount of flexibility or laxity in terms of allowing one's team to actually deliver the appropriate amount of education at the right place and at the right time. I should also mention that self-care dialysis is growing in different parts of the world. There are different models, if you like, a spectrum of autonomy that's being offered across the world. So, for example, what I mentioned earlier today is the independent home dialysis. In other parts of the world, Canada, Europe, and so on, there are home-assisted dialysis, where a personal service worker or nurse might actually go to the patient's home, do peritoneal dialysis connection and disconnect, and allow that to actually occur. In other parts of the world, there's community housing dialysis, where a particular regional center is in charge of operating that dialysis house. Each room actually is configured to actually deliver dialysis, but patients actually learn how to do the self-care and has a self-booking system that they can actually come and go to actually allow the dialysis to be delivered. So I think you will see, as we evolve in this idea of independent dialysis, that there will be a whole spectrum of assistance.
Thank you. I love how you also, place that concept that the patient is a co-creator in this process. The patient's expertise matters just as much as the trainer's expertise. And
Right.
I love how you flip that concept of the OSCE to say, how are we teaching this content to patients to apply OSCEs, simulation, all to patient education? How did you come up with that idea of adopting those conceptual models from the med-ed world?
Well, thank you. Actually, a lot of it is not just my own thinking. A lot of it is the team approach. And in Toronto, we have been operating a home dialysis fellowship for the last 20 years or so. And many of these ideas were co-created with our fellows and our nursing, and really basically looking at our training center as a living lab. And many of the complex skills that we teach, we also teach medical trainees. So it is quite translatable and understandable that we can use these items that we often are looking at it only in the medical education lens, but didn't apply it in the patient lens. And so, for example, home hemodialysis is a relatively complicated machine. And oftentimes, we are not actually thinking about it that way. And I can tell you that original genesis of this idea came about when my son was learning how to drive. And so when he has to pass a practical test and also a theory test, and I said, well, we're practically doing similar stuff with patient training, but how come we never actually test and assure that they actually understand what they're doing? I don't need to know if they truly understand what hemodialysis machine and how it works, just like we don't need to know that how a car engine works, but we certainly do need to know the skill in terms of passing your driving test. So that's how we actually came about with the idea of doing OSCEs and also simulation.
Brilliant. From the teen in driver's education straight to the medical education lab and then to patients worldwide. We have a great question here from Dr. Lee, who's one of our infectious disease faculty, who says, in the HIV world, the patient advocate is a key driver for care improvement. Is there a role for patient advocates in expanding home health dialysis?
Yes, clearly. In the HIV, in fact, actually, there's a lot of aspiration that comes through in the HIV world, and also other virology worlds. So the whole world of ECHO project comes from HIV and also hepatitis C. And we actually borrowed that idea in translating that to physician education. Home dialysis is heavily advocated by patient advocate. I co-chaired a National Kidney Foundation home dialysis task force, and in fact, the patient partners and advocates are a huge component of it. They speak to us in a different lens. The knowledge awareness, the anxiety of doing dialysis, the fact that when some patients actually learn that they are on dialysis, it's the first time that they know that they have kidney disease. The amount of fear that really take the patients completely away from the possibility of learning the feasibility of doing home dialysis. The fact that peer-to-peer mentors sometimes actually do better in teaching and also convincing someone how to actually undertake home dialysis. So as a matter of fact, as I mentioned, we just finished another project with collaboration in NKF and a end-stage kidney disease network in a Project ECHO, where we invited different centers and nursing and allied health to join. And we just finished and closed that project, and we'll be looking at the data and assessing centers that participated in ECHO versus centers that did not participate in ECHO, and looking at the home dialysis adoption rate.
That sounds like a really interesting project. We'll definitely look for those studies to come. And I think on your theme of borrowing from other disciplines, we've seen this movement of home-based primary care, or the
Yep.
hospital at home,
Yep.
EICU in my world. What other applications might you see of this, virtual ward technology that you alluded to?
Yeah, no, I think that's really quite important. And so in my other portfolio as the medical lead for connected and integrated care for UHN, we're really looking at this entire end-to-end solution of bringing the subspecialty world, the hospital admissions, and also translate that into the community. So I think in the home dialysis, I think the different level of support, be that home assisted dialysis, be that changing that communication modality, how do we actually communicate with our patients? How do we actually alert ourselves and also with our patients? And finally, the importance of maintaining this technique. How do we assure that this dialysis is being done day in, day out? And finally, the teaching component, both to the patients as well as to the family. So I think there's going to be a lot of synergies with evolving technology. And also as the machine becomes simpler and simpler, there's going to be also further enhancement of how we're going to be able to communicate both within ourselves and also with our patient population.
That's a great point. I think another question from the audience by Dr. Polavoy from the emergency department is thinking about factors why patients might fail. Is this technology appropriate for our elderly population? What about, have you seen barriers or inequities by socioeconomic status and race? And again, how might our health system, even particularly in the US, perpetuate some of these inequities?
Yeah, this is a very important point, and it is a huge point. And I think we're just trying to break down some of those barriers. Clearly, in order for you to do home dialysis, you must have a stable home. And as I mentioned briefly, even just looking at rental status versus owning status, the renter has a 5-fold increase in technique failure compared to someone who owns. And this actually is associated with a constellation of health literacy, social economic status, the amount of effort and also help that they may actually able to do at home. So I think as we understand that more, we're starting to look at racial differences in adopting home dialysis. It may not be surprising to many of the audience that there is a difference amongst Caucasian patients versus Black patients in adopting home dialysis. All the visible minorities tend to have a different rate of home dialysis, be that culture or be that knowledge awareness. So I think there is a significant knowledge penetration campaign that we need to do, and also allowing us to truly be transparent and understand that dialysis access has to be equitable. And also, what are the ways that we can allow the delivery of dialysis to be more equitable? Right now, we're only in the exploration phase, and I think there's lots of work that can be done and ought to be done across the board. And perhaps there might be policies where governments may allow assistance to be paid or reimbursed in patients who are unable to actually do home dialysis.
Well, thank you so much, Dr. Chan. This was just a fascinating hour. You taught us all a lot. Thank you for educating us all about home dialysis, everything from economics to policy to equity to science to med ed. We really appreciate it. And we'll see you all back next week for another COVID Grand Rounds. Bob will be back, and we're going to have Dr. Zeke Emanuel and Caitlin Rivers talking about COVID policy next week. Thanks again, Dr. Chan. Thanks everyone for listening. Have a great rest of your day.